high above Caesar Rodney Square in beautiful downtown Wilmington, Delaware, we are the Podcast Pediatricians. I'm Rob Walter.
And I'm Matt Gotthold. If you like us, keep telling your friends and family to listen and to subscribe to Podcast Pediatricians on iTunes, Google Play, and Stitcher. Plus, check out podcastpediatricians.com, where you can also find and play all of our episodes with crazy pictures, etc. And you can leave your email address to be added to our mailing list. And also give us feedback and suggestions. Welcome to Penis Part 2.
And we promise to never, ever, ever discuss the penis or even say penis on this podcast again after this episode.
At least keep it to a minimum.
Exactly. But first, boys and girls, a few tidbits in the pediatric news. So, Matt, the Tooth Fairy payouts in 2017 were announced recently, and the average tooth price dropped 11% despite a hot stock market in 2017, which is surprising since the Tooth Fairy payouts usually go hand in hand with the Standard & Poor 500 index. The average tooth went from $4.66 down to $4.13, or a 53-cent reduction in this survey of 6 to 12-year-olds. And the first thing I thought of was, what 12-year-olds are still getting money from the Tooth Fairy? Maybe South Jersey. Did they have a Tooth Fairy in South Jersey? Did the Tooth Fairy just come and steal your tooth? Was it the Jersey Devil?
In Jersey, Rob, sometimes actually having teeth can be the issue. Oh, man. On the West Coast, the Tooth Fairy was the most generous, averaging $4.85 per tooth, followed by the Northeast and then the South. And the lowest payout was apparently in the Midwest with $3.44.
What's the most you've heard? I've had a couple families over the years that gave $20 for the first tooth. I'm like, if you're starting there, you really don't have a lot to go.
What did you used to get?
Maybe $1. I used to save all my teeth. It was disgusting. I had like a drawer, I had a bag, and I had like 30 teeth in there, from all ages. So.
I think
my mother.
We got like dimes and quarters, I think, at my house. Yeah. It wasn't terribly festive at my house when it came to the remuneration there.
Do you remember the movie Tooth Fairy with Kirstie Alley? It was one of my kids' favorites. It's 1997. A mean dentist dies and ends up in limbo between heaven and hell, and it's forced to be the Tooth Fairy. It's Kirstie Alley. Now, they can't remake this now because Pope Benedict got rid of limbo in 2007. Did you know
there can't be a remake. Well, there can be a remake at least, but it won't be reality based.
I feel like I need to tell you about the Catholic theology sometimes and up-to-date you that there's no limbo.
Next, we are sad to report that T. Burry Brazelton died in Massachusetts last month at the age of 99 years old.
1 month short of his 100th birthday.
Wow. He was a giant in child development research and was a primary care pediatrician in Massachusetts for over 50 years. Dr. Brazelton designed the landmark Brazelton Developmental Scales, which are still used in many sectors these days, and he did this in 1973. After writing a seminal book on pediatric development called Infants and Mothers in 1969.
And he really pioneered looking at babies as individual people from the very beginning. And he later had a series of touchpoint books. Do you remember those?
I do. They're good.
That were wonderful. And I actually got to be on a panel with him back in Nemours in the 1990s. And he was just a kind and gentle soul and will be sorely missed as a giant in pediatrics. Okay, we're going to cover 2 new teenage addictions, and we'll probably talk more about them in a future episode, but I just felt like we had to touch base because it's all over the news and we're seeing it in the office. And the first one, Matt, is Juuling. That's Juuling, which is a newer vaping aerosol e-cigarette device that looks like a flash drive. It's long and rectangular, and you can charge it in a USB port of a laptop. It comes in multiple flavors like mango, creme brulee, and fruit, and it's loaded with addictive nicotine. Now, the Juul company says, as all e-cig manufacturers say, that they're just there to help current smokers get off tobacco, but I call BS. I think they probably always knew that much of their sales would come from non-smokers and often teens.
One flavor pod for Juuling gives 200 puffs and has the same amount of nicotine that there is in a pack of cigarettes. A starter kit with a Juul device and 4 flavor pods, plus a USB charger, costs less than $50, and each pod costs about $16 separately. The devices are so small that some teens wear them on their necklaces, or put them in their hair, or clip them to their backpacks or belt, or onto their shoelaces so they can use them in school, and even potentially in class without being detected. This becomes a nightmare for educators and for school administrators.
And a 2017 NIH survey showed that 19% of all 12th graders and 16% of all 10th graders and 8% of all 8th graders reported vaping nicotine in the past year. And as we know, nicotine can rewire an adolescent's brain, and it's addictive. Big Tobacco is all in on e-cigarettes, and the market has grown by 40% this year to $1.16 billion, $225 million of that from Juuling. Studies also show vaping can include heavy metals, and Juuling, which is more of an aerosol, can have other harmful chemicals and toxicants. Juuls are for sale all over. Now, Matt, you can buy Juuls at the Wawa anytime. How is my Philly accent? Delco accent? What do you think?
Yeah, it needs some work, man.
Okay.
Stick to Long Island.
Okay. Last May, the FDA allowed e-cig manufacturers a 5-year extension on a rule requiring them to prove that their products are just safe. To me, it's kind of the $22 million that Big Tobacco spends each year to lobby paid off. This week, I think we both read in the paper that the FDA is starting to crack down on retailers of Juuls online, in gas stations and convenience stores, selling to anyone under 20 years of age, although I think it's kind of too little too late. It is a nightmare.
The second addiction is Fortnite, a video game which is also overwhelming educators by its sheer presence in schools, with teens playing this online game on their smartphones potentially all day long. 3.4 million people played Fortnite Battle Royale on a single day earlier this winter, many of them teens. This Battle Royale version of Fortnite was only released in September of 2017, and it is an online sensation. Rob, over 600,000 people watched a live match between the rapper Drake and several pro football players.
And you know, this Fortnite's a lot different than the other obsession over the last 5 years, which is Minecraft, where you build things and you maintain health. In Fortnite, players team up to fend off a zombie apocalypse after a worldwide windstorm causes 98% of the world's population to disappear. About 100 players board a flying blue school bus suspended from a hot air balloon and then skydive into an island where they look for weapons and build forts for protection and kill anyone they see, mainly the zombie-like creatures who rise to attack them. And the last one standing wins. Now, to be fair, the Fortnite game world is supposed to be beautiful, and the avatars include many cartoon characters, which are very funny. I've known multiple people who really like it. I like The Walking Dead. I'm not against zombies, but it has this really addictive quality that we're starting to see in the office where parents are saying they can't get their kids off it. But, Matt, all those news aside, the big news since we last talked in Pediatrics was obviously that Bozo is dead. Bozo is dead. She had a few weeks ago, Frank Average, star of Bozo, the clown, in Boston from 1959 to 1970, passed away, and it made national news. So, gotta ask Matt, did you like Bozo?
Not really. I was more of a Captain Kangaroo kind of guy. Yeah, Mr. Green Jeans. He was the man.
They're okay. I didn't like that haircut.
Oh, no, that haircut rocked. 1955 to 1984, the longest-running national broadcast of a children's television program in its day, and still the longest-running that was not public television, with Sesame Street being the longest.
Wow.
And, fun fact, it premiered the same day as the Mickey Mouse Club, October 3rd, 1955, just on a different network. So, go Captain Kangaroo.
All right, I got to go back, but I really loved Bozo. But what I found out in a deep Bozo dive is that this Average was only the first nationally syndicated Bozo from his base in Boston. There's been over 200 Bozos from around the country and internationally. Average was also a longtime Boston TV personality who was much beloved, but he is not the Bozo. He was just the Boston Bozo. And Matt, wouldn't you agree that you can really say that everybody from Boston is a Boston Bozo?
The only ones that I see are the ones who come to Phillies games and Eagles games.
As Tina Fey memorably said, Boston is just a college town with a fishing pier.
Okay, some more Bozo history. A gentleman named Larry Harmon actually bought the rights to Bozo in the 1950s. The very first Bozo was on a recording by Capitol Records in 1946, created by Alan Livingston and voiced by Pinto Colvig, who also was the voice of Walt Disney's Goofy.
Ooh.
And as we keep asking ourselves, if Pluto is a dog, what the hell is Goofy?
My personal favorite Bozo growing up in New York City area was Bill Britton on Channel 11 WPAX, also known as the Yankees Channel. And then there was Gordon Ramsay on Channel 9 WOR, the Mets channel in the late 60s. Bozo owned the weekdays, but on the weekends, we had our Wonderama on Sunday mornings. Did they have Wonderama in Jersey?
We did not have Wonderama.
Oh, it was so good in the 60s and 70s, Sonny Fox and Bob McAllister. And there were two famous songs. Do you know either one of these songs, Matt? First one, Kids Are People Too. Kids are people too. Now you say wackadoo, wackadoo,
wackadoo, wackadoo, wackadoo.
It isn't easy going all day, winning and losing in the games that we play. Doing our homework, working in school,
wackadoo,
trying to
wackadoo.
live by the golden rule. And then the second one, anybody here got an aardvark? Everyone here has a right and left ear, but nobody here has an aardvark. You don't know any of those?
No.
Such a deprived childhood. I understand.
Not deprived.
I understand what happened to you,
just
Matt.
Different.
Okay, you're just different, Matt. I understand why you did not really follow Bozo, because Bozo was not big in Philly. There was only like a total of 4 or 5 years with a Philly Bozo, WGBS, WTAF. But I did find a clip, and it shows this little 5-year-old from Huntington Valley with his dad going on the grand prize game with the ping pong balls. And they ask him, what do you want to be? I want to be a lawyer and a doctor. Like, wow, great. And then he wins the first two. So first prize was a carton of Juicy Juice. And then if you get to the next stage, you got a carton of Tootsie Rolls. So quite
they were really going overboard
show.
There. Yeah. No, I've honestly, I've tried to block Bozo out of my consciousness, kind of like post-traumatic
Well, and you're from
experience.
this area, so do you remember Al Alberts?
I do. Yep. I remember Al Alberts, but I remember most Captain Noah and Sally Starr and Wee Willie Weber. Yeah, they were all native Philadelphian fare. Yeah, in retrospect, the theme song for Captain Noah, which I think actually Andy Williams originally recorded, it kind of invokes images of like an LSD trip, because it says like red and yellow and pink and green, purple and orange and blue. And here's the part where it gets creepy. I can sing a rainbow, sing a rainbow. Sing a rainbow.
No, it got creepy before that, Matt.
Well, wait a minute.
Check
this out. Listen with your eyes. Listen with your ears. It was weird. But Captain Noah would sing it every time. And Mrs. Noah along.
Captain Noah's on LSD.
It was crazy.
Al Alberts, who I didn't grow up with, but he had this showcase with dancers, and he's the guy who sang On the Way to Crepe May.
Oh, yes,
right?
I do remember.
You know that song.
Yep.
So I remember him as an older guy sitting in a chair with all these little girls in tutus and dancing. And I got to say, it was like, this is the creepiest thing ever.
You let your head go there. I mean, to us, he was like, a great uncle.
Oh, he looked like a creepster. But I've read that people really loved him, and he launched a lot of great careers. Here's your Bozo trivia question, Matt. Who played Bozo in Washington, D.C., and then was also the first TV Ronald McDonald?
I don't know.
Willard Scott, Today Show weatherman.
Oh, okay.
Last Bozo thing, the very, very pinnacle of Bozo was Chicago. It was the most popular and successful locally produced children's program in the history of television. Now, I don't know where that ranks up with Captain Kangaroo, but that's what it said in the website. Bozo Circus debuted in Chicago in 1960, and it was the last Bozo standing when WGN and the Tribune Company shut it down in 2001. And back in the day, that was the most prized ticket in Chicagoland. People would register their children in utero before they were born to get a ticket to Bozo.
Sounds like some of the daycares in Manhattan.
Exactly.
All right, then. Let's finish up with the penis as we move down to the scrotum. We'll be right back.
We are back.
Okay, we're ready to continue our discussion on the topic of the penis. As promised, we're moving south to the scrotum. We will start with newborn issues.
But first, our disclaimer. We are sharing our own personal opinions on pediatric care. Always talk to your own pediatric caregiver about your child. Pediatric caregivers should always consult expert guidelines and consider their own community's standards of care.
Okay, Rob, if we're talking about newborn scrotums, a good place to start is with the hydrocele. Hydroceles involve the painless collection of fluids, basically water-like fluids, around the testicles. It's pretty common in newborn boys and usually goes away within a few months. It's caused by the delayed closure of the process vaginalis, which is an opening which connects the abdominal cavity to the scrotum, and through which the testicle descends as it moves from the abdomen into the scrotum during fetal development. In newborns, a hydrocele is almost always non-communicating. This means it does not directly communicate with the abdomen any longer. With this situation, the hydrocele gradually shrinks as the fluid is absorbed.
And these babies who are born with bilateral hydroceles, which is pretty common, come out with pretty big scrotums filled with fluid. And I have to say, sometimes dads are kind of beaming during the exams, like, whoa, look at my boys down there, even though it's really just water.
Yeah. So these are kind of known as faux balls, which may be where the term foibles comes from, I was thinking, all right. An examiner can confirm that a bulging scrotum is a hydrocele by simply putting a light source, like a pen light or an otoscope, against or behind one of the side of the scrotum. If the area transilluminates, meaning that the light shines through the scrotum because the enlargement is due to fluid, that cinches the diagnosis.
Right, so it kind of glows like the sun at sunrise over Asbury Park. Right?
It glows like Billy Joel's noggin. If the light does not shine through, then there's a concern for an enlarged testicle or a mass or a hernia. More often than not, the hydrocele will resolve with time. If the hydrocele is not resolved by about 1 year of age, we'll usually refer the baby to urology to consider repairing it, since a persistent hydrocele can be associated with a hernia later on.
Now, if later there's a hydrocele that's communicating with the peritoneal cavity, it's called a communicating hydrocele, and it'll get bigger as the day goes on, or if you valsalva or clench your abdominal muscles while expiring. These communicating hydroceles are more common again in the older boys, and they do usually need to be repaired to prevent a hernia. Hydroceles also occur with any kind of inflammation or trauma to the scrotum or testicles. And I've seen a few teens who suddenly get a big hydrocele with no history or trauma or anything, at least that they admit. These can get pretty big and uncomfortable. And when I see one at first, I think, is this a mass or an emergency testicle condition? But again, as Matt said, you put that little pen light on it and voila, it transilluminates like a shining, glowing pink Christmas tree ornament, and that is a big relief.
That is not an ornament I would want on my tree. Honestly, the pickle is weird enough.
I don't know. Now, I had a kid, a young man last year, I think high school age, who came in for his well visit, and he said it's been swollen for weeks, and it was huge. Didn't hurt. It did transilluminate. And I was like, dude, if something blows up like that, you got to tell somebody. Don't wait for your well visit. What if you didn't have a well visit for 10 months? And especially there.
I had the same situation happen. I had a guy who was a teenager. He's probably in his 30s now, who came in complaining of lower abdominal pain. I'm doing my abdominal exam, and all of a sudden I go to do a groin exam, and there's this humongous hernia there. I'm like, Kevin, you think you might have told me about that?
What's that?
And he said, well, I figured you'd find it. Crazy.
It was a test.
Absolutely. Oh, my goodness. Anyway, so moving on to the testicle. Cryptorchidism is when a testicle does not quite get to its typical destination and fails to make it fully into the scrotum from its starting point inside the fetal abdomen. Sometimes there's just simply no testicle at all on one side. This can happen due to vascular accidents in the womb. On Long Island, that's called a uniball. Not to be confused with a unibrow, which is unusually high incidence also in Long Island. There is, fortunately, no South Jerseyan correlate to this. As a young man with a single testicle grows older, a prosthetic testicle is oftentimes placed in the empty side of the scrotum, or not, depending on the young man's wishes. Now, if the examiner cannot detect either testicle, one needs to be thinking of possible disorders of sexual development. This consideration would need a comprehensive and careful and sensitive evaluation.
And that's what we talked about last episode.
Absolutely. However, most of the time, the discovery of an undescended testicle means that it somehow got waylaid on the normal descent from the abdominal cavity into the scrotum. In typical fetal development, this occurs around 20 weeks of gestation.
Now, 2 to 5% of all full-term babies and up to 30% of preemies have undescended testicles, so it's pretty common. Cryptorchidism is also more common in certain genetic conditions such as Prader-Willi, Noonan syndrome, and more commonly Klinefelter syndrome, which are boys that have an extra X chromosome. They also have smaller testicles than expected when puberty starts. And since testicular enlargement is the very first sign of puberty in boys, whereas breast buds are the first sign in girls, it's important to note if the testes seem too small, if they're not growing while a boy's going to puberty, you probably need to check a testosterone level and get a generic karyotype.
With true cryptorchidism, the scrotum on the affected side is usually small and rather underdeveloped. Most commonly in cryptorchidism, the testicle is near the top of the scrotum, but if it got stuck earlier on its descent, it can be in the groin or even higher still in the abdominal cavity, where it cannot be felt at all. In that case, an ultrasound can be used to look for it. Now, if the newborn cryptorchid undescended testicle does not descend nicely into the scrotum by 4 to 6 months of age, then the infant should be seen by urology. These children, and those with intra-abdominal testicles at birth, require a procedure called an orchopexy, in which case the surgeon brings the testicle down into the scrotum and essentially tacks it down, so it can't reascend. This decreases the risk of testicular cancer and infertility issues in the future. Changes in the testicle, which can lead to infertility, can begin prior to 1 year of age, so this type of referral should not wait too long.
And that's something we should stress. I mean, you really can start having long-term change in fertility if you don't jump on this during infancy.
Yeah, and I think initially we were taught up to a year, and the newer guidelines have lowered that to 4 to 6 months.
Right. And now get this, boys and girls. The palpable testicle sometimes can ascend or go upward from the scrotum back in the groin all by itself. This may be later in childhood, often at 4 to 8 years of age, and may also need that orchiopexy. This is another reason why routine physical exams yearly are important. It also reminds me of Elaine and George in the Seinfeld Hamptons episode when she was flabbergasted that the penis could shrink in the cold ocean. Yes, it can shrink, and a testicle can shoot up into the abdomen out of the scrotum all by itself. Do you remember that episode?
I think you base your life on Seinfeld episodes. The ascended testicle phenomenon must be differentiated from the way more common finding of retractile testes, which is benign, in which case the testes move up and down from the scrotum into the groin, especially when the child is cold or crying. It can be tough to palpate these testicles sometimes. The muscle that elevates the testicle is called the cremasteric muscle, one of the coolest muscles in the body, in my humble opinion.
You have a ranking of muscles?
I do. Actually, the cremaster is right up in the top 5, I think.
Someday we'll have to get your list.
It's very cool. I mean, haven't you ever thought like, okay, what's the evolutionary advantage of this? And the evolutionary advantage of it is like, okay, somebody's about to take away the family jewels, so let's run up toward the body, right?
Good point.
It's actually a pretty cool muscle.
Good point. Mm-hmm. So in these boys, and you try and do the exam, and the testicle keeps running back up, it can be hard to see if it can get it down. So one technique in these difficult cases is you take one hand and milk the testicle down, starting from the top of the inguinal canal near the iliac crest and go downwards towards the scrotum. And then you use the other hand to see if you can feel that testicle going into the scrotum. And it's challenging in a cold, ticklish boy. We've been taught that it's easiest to do in a lukewarm bath, but I'm not running a lukewarm bath in my office.
We don't have the lukewarm bathroom in our office.
We do not. But at the very least, we got to warm up our hands.
Yeah, for sure. If you can get the testicle into the scrotum in the office, it's likely going to be okay, and you can just follow it along with routine exams each year. But if it's really difficult to get it down and it slips right back up again when you let it go, then the boy probably needs to be seen by urology eventually. Overall, most truly retractile testes usually stay down for good as a boy goes through puberty, but about 5% of retractile testes become ascending.
But I would also add that if the scrotum is really underdeveloped on that side compared to the other, it might be another reason why you may refer them sooner than later. And lastly, if you're unsure if it's retractile or truly undescended, or if the testicle just feels funny or different than the other testicle, or maybe atrophic or maybe even ectopic testicle in a place other than the scrotum, just refer to urology.
So you're ready to discuss inguinal hernias, Rob?
I was born ready to discuss inguinal
Straight.
hernias, Matt.
A hernia is a protrusion of an organ or tissue through an abnormal opening. There are many types of hernias in both males and females, and most are not in the realm of this podcast. But we'll just mention that an inguinal hernia is a herniation from the abdomen into the groin, and sometimes from the abdomen to the scrotum, and can include part of the intestine. If it's very painful and or swollen, this can indicate that this is a medical emergency. A hernia can cause an incarceration, meaning becoming trapped, or a strangulation of the intestine or tissue. The tissue which is herniated can get squeezed so hard that the hernia cuts off the blood supply to the tissue, which can lead to tissue or bowel damage and to a life-threatening bowel obstruction that can sometimes lead to infection and sepsis.
Now, sometimes an inguinal hernia in a child appears and disappears as a bulge on one side of the groin, so it's good for parents to take a picture of it if there's any concern about a hernia. If there is a hernia, it will eventually need to be fixed, hopefully using the newer, minimally invasive techniques laparoscopically. So, Matt, do you routinely do a separate hernia check on your visits? You know, the classic turn your head and cough on especially the teenagers?
I sure do. Absolutely. Yeah, I usually start doing those somewhere between 8th and 9th grade. Yeah, I actually have them, stand up, give me the cough, whole 9 yards. So what usually happens is I get this wimpy little cough, and I need to encourage them to give me a better cough, commenting that I realize it's tough to muster a cough when somebody's putting a finger in your scrotum. And that usually gets a laugh, and the laugh itself creates almost like the cough in the Valsalva. So works well that way.
Not sure they're finding you funny. They just want you to get their finger out of their scrotum, I think. So
pretty much.
One of my favorites now is varicoceles of the scrotum. Now, I personally never saw these until I went into private practice, and they are pretty common. In fact, I never really learned about varicoceles in residency or medical school, and the first time I felt one in practice, I was like, whoa, a full Ignatius J. Riley, whoa.
I think that was more like, whoa.
That's better. That's good.
And it wasn't Ignatius in that novel. It was Burma Jones.
Oh,
yeah, Burma
right.
Jones and Confederacy of Dunces. He said, whoa, all the time. And I know that because for our book club, I listened to it, whereas you actually read it.
Matt doesn't read the books. He listens to the books. I feel like
it's
that's a little bit dishonest.
Stuff. Come on now.
I don't know.
All right.
So varicoceles are usually left-sided and can get really, really large. It's often called a bag of worms, and this distasteful description is exactly how a varicocele feels on exam. Although bag of worms is also a popular snack that Matt had growing up in the Pine Barrens.
Not to be
Little
confused
Matt,
with
you want some bag of worms?
Not to be confused with bag of night crawlers, which the older kids got.
So varicoceles are really dilated veins that back up from the left renal vein into the scrotum and can be seen in about 15% of postpubertal men. It's most impressive when standing up, as the veins become engorged because of gravity. So if you feel a varicocele very easily during your routine exam when the child or teen is laying flat or supine, then the odds are it's going to be really big when you feel it when they're standing up. And sometimes when I find a huge varicocele in a routine exam, I look at the young man and say, did you notice this huge bag of worms filling up half your scrotum? And they usually shrug and say, nope, never noticed it.
Kevin, were you going to tell me about that?
Nope.
Same kind of thing, see? If the varicocele is relatively small, with no symptoms, and the testicle on that side is not smaller than the other side, then we can just follow it. But if it's large, especially if there's any discomfort or any indication that the testicle on that side is smaller, or in the rare case that there are bilateral varicoceles, then it's wise to get an ultrasound. The guys with these types of varicoceles usually need to see a urologist. However, the procedures available to fix a varicocele aren't always very successful, and a good urologist is always cautious about going down this path. Still, a large varicocele can decrease fertility, so it's important to follow it closely. Rob, do you tell your adolescent boys to do self-testicular exams?
I do, just like I tell young women that they should start doing self-breast exams. However, I've read multiple places that suggest that it's not worthwhile to do this, but I just don't agree. Yeah, we'll get some false alarms like cysts, which we'll get to soon, but over the years of my practice, I've had multiple teen boys present with a testicular mass that was important that they found first. Although I do think that most teen boys are doing their own self-exams down there pretty regularly, although maybe not all the way down to the scrotum.
do you remember the Surgeon General masturbation thing?
Oh.
Yeah.
Jocelyn Elders.
Yeah, in 1993, Dr. Jocelyn Elders, who was the first African-American Surgeon General, was fired by President Clinton for suggesting that, as part of human sexuality education, students be taught about masturbation in order to reduce unsafe sex and unintended pregnancies and diseases. She got fired for it, although she did clarify that she meant that they should learn that it is natural and common, not that they should be taught how to do it.
So it's all flooding back to me. And I remember one thought I had then and one new one now. The first thought I had then was, do you really need to teach teenage boys how to masturbate? I don't really think so. The second thought was that perhaps Bill Clinton, who fired her, may have learned how to do that, and then he wouldn't have ruined Monica Lewinsky's life,
Yes.
and we would have had President Gore, who succeeded him.
Yeah.
That's how I think of it now.
Yeah. When a teenage boy comes into the office with a concern that he thinks there is something abnormal with his testicle, it's usually an epididymal cyst, also known as a spermatocele, which is a cyst of the epididymis. The epididymis, which is a maze of tiny, tightly coiled tubes that carry sperm from the testicle and which helps the sperm to mature, is a natural part of the anatomy. These spermatoceles are usually at the top part of the testicle, and an examiner can feel them separate from the testicle. If they're large enough, they'll transilluminate, just like hydroceles, since they are full of fluid. If an examiner is not 100% sure that as it separates from the testicle, or if it does not transilluminate, then an ultrasound can be helpful. When in doubt, get that ultrasound.
I had a kid last year that I thought had an epididymal cyst, but it also felt kind of weird around it, and I wasn't sure, and ended up getting an ultrasound which showed a hydrocele over an epididymal cyst, and they did end up repairing it. So again, when you're unsure, get an ultrasound.
For sure. I mean, true testicular cancer is not common, but it's one of the most common cancers in young men. The testicles are also a place where a previous cancer can precipitate cancer, which can occur with leukemia and lymphoma. Once again, if there's any question of testicular mass, get that ultrasound.
And as we mentioned, the testicles can be too small, which can be caused by certain hormone or genetic conditions. Steroids can also cause shrinkage of the testicles. Again, not to be confused with George Costanza's shrinkage of the scrotum after his ocean dip. Yes, I love that episode.
All roads lead back to George Costanza's scrotum.
The sea was angry that day, my friend.
Yes. A testicle can also be extra large, which is called macroorchidism, which is a feature in the most common cause of genetic mental insufficiency after Down syndrome, Fragile X syndrome.
There also are testicular volume measuring devices called Orchiodometer beads, which are 12 wooden beads of various sizes, which was invented by a Swiss hormone doctor endocrinologist in 1966 to estimate the volume of a boy's testicles. Now, prepubertal testicles are about 1 to 3 milliliters. A teaspoon is 5 milliliters. Pubertal testicles are 4 and up, and adult testicles are 12 to 15 milliliters. Since the first sign of puberty in boys is that testicular enlargement, it could be handy to measure testicular changes in boys with delayed puberty by using these beads. These beads are also called the endocrinologist worry beads, and pediatric endocrinologists really love their
yes, they do.
Call them their testy beads.
Yes.
And that's why I was surprised when Matt showed up at his residency interview wearing Orchiodometer beads around his neck. I guess it was a fashion statement in South Jersey.
You know what?
Or Hahnemann, perhaps.
I thought I might want to be an endocrinologist, and I was making a professional declaration and a fashion statement at the same time.
And it worked.
Yes, here I am.
We'll be right back with Choosing Wisely. We are back with Choosing Wisely, but first, Matt, I forgot about our snack. Today, I brought Tate's Bake Shack from Southampton, New York. That's Suffolk County, Long Island.
They look very chocolatey.
This is the double chocolate chip cookie. Oh. What do you think? Long Island cookie.
Crunchy. Chocolatey.
It's good.
Mm-hmm.
I just say it's good.
It is. You know, after the crunch, I expect it to taste a little burnt, but it doesn't.
Like a Long Island...
like everything else from Long Island, yes.
Okay, well, you finish your cookie, Matt. Choosing Wisely. Are you choosing wisely, Matt? Do you know about the whole Choosing Wisely initiative?
I'm choosing wisely by finishing this cookie. Yes, it's an initiative by the American Board of Internal Medicine, launched in 1999 to improve healthcare. It promotes better doctor-patient relationships and patient-centered care by educating doctors and patients. And for us as pediatricians and the parents that we serve, it's also about overutilization of medical resources. It chooses care that is supported by evidence-based medicine, free from harm, truly necessary, and also avoids duplicating care.
Now, our American Academy of Pediatrics, AAP, became part of Choosing Wisely in 2013, and we've collected some of their Choosing Wisely guidelines, and just going to see if Matt and I agree on most of them. So the first 5 came out in 2013 for general pediatrics. Number 1, antibiotics should not be used for apparent viral respiratory illnesses, sinusitis, pharyngitis, bronchitis, bronchiolitis routinely. Agree?
What I will agree to is the fact that that cookie kind of tastes like crunchy hot chocolate. But not hot.
We
it was
moved
good.
on from the cookie,
Oh,
Matt.
okay. So, yes, I agree 100%. Antibiotics should not be used for anything that says viral, first of all.
Well, it means if it's probably viral, except
Right.
if you're in an urgent care center, I guess. Then
Where everything is treated
yes,
with antibiotics.
with antibiotics.
Yes. Okay. Cough and cold medicines. This is number 2. Cough and cold medicines should not be prescribed or recommended for respiratory illnesses in children under 4 years old. It states that most of these meds have multiple ingredients that increase the chance of accidental overdose and offer little benefit and potentially serious side effects. What do you think about that, man?
Oh my gosh, I so amazingly agree with that. And I have to shout out to Dr. Lisa Horton, who's somewhere in Maryland, who 25 years ago was shouting this when she worked in the ER at University of Maryland. It took everybody a long time to catch up. I sometimes call this stuff Pediacrip.
Oh, yeah.
And especially I don't like using Sudafed. That's in a lot of these multi-ingredient medications.
Yes.
Now, I have some families who just love Sudafed, but I just don't like the headaches. I don't like the thickening of the mucus, so I try to stay away.
Right. It's interesting because when I started my residency, one of the most laborious tasks that I made myself do was to write down all of the ingredients of all of the things that were out there at the time, so that we were on call at night for our population that we took care of, and somebody called and said, "What should I give my child? For their cold?" I would know exactly what was in Pedicare DM or in Dimetapp SKU or what,
And every pediatrician had their favorite. Like there's one guy who just everybody got Bromfed.
Yes, yeah.
Your toe hurts? Try some Bromfed.
And that was very common. And it was in the midst of my residency, at least, that from what I recall, studies were done. They were done, I believe, at Harvard and at Hopkins, kind of concomitantly, that both indicated that number 1, kids that age group don't benefit at all from these medications, and in fact, they can be potentially harmed from them. Crazy, crazy stuff. And there's an entire, God knows how many billion-dollar industry built on nothing.
Right. And even though this says under 4, I don't like to use it at any ages.
Yes.
It's hard to get the college kids not to do the Dayquil, NyQuil thing.
Right.
And sometimes they need to sleep, but I really don't like, until they become fully adult, I really stay away from these.
Yeah, I generally discourage people, especially from cough medicines, which when we cover cough, we're going to discuss.
Unless they can't sleep at night and it's simply just for cough, I can live with that. But otherwise, you want to cough and get that out so you don't get pneumonia.
Well, I mean, the fact that the cough medicines in general really have never been proven to be any more efficacious, including the narcotic ones, any more efficacious than honey.
And we don't use those anymore.
No.
Honey's good.
Crazy.
Except if you're an infant and you get botulism.
Yeah.
Number 3, CT scans are not necessary in the immediate evaluation of minor head injuries. Use specific pediatric emergency criteria to determine whether imaging is indicated. Amen to that. And I think there's so much radiation, and our area hospitals really have taken that to heart.
Yes. I mean, and thankfully most of what we deal with are pediatric hospitals, which are already kind of sensitive to over-radiating someone.
Right.
And the horrible things that can come from that. Number 4, neuroimaging like CT or MRI is not necessary in a child with a simple febrile seizure. Rob, what about a single, short, non-febrile seizure? You do anything with that?
That's tough. I gotta say, I haven't had one of those in years. and I do punt to neurology when I have a non-febrile seizure, but if they're younger, if they're like 1 or 2 or below, I think at some point you're going to get an imaging test.
Yeah.
If they're older than that, and I think all of them should get an EEG, and if they're older and everything else is fine, it was one episode and the exam is fine, and the EEG is fine, you probably don't need to go through an imaging test. But the younger ones, I think, should. And these days, it should be MRI.
I agree. I think the MRI is necessary. Again, I would defer to neurology on this one, but the EEG, as you said, is probably the most important piece here. They should definitely have that done. MRI, I just encountered the other day when I was talking about something a little bit different with one of the parents in my practice. A lot of people are just scared to death of the sedation that you need to use in a young kid. Even if it's in the hands of somebody who's a pediatric anesthesiologist, they're still leery about putting their kid out to have an imaging study done of any type. And so you got to respect that, although I try to let them know that the chances of anything, sinister happening are really, extraordinarily slim. Again, they're balancing the pros and cons here.
Right. So if you're going to do it, you should be in a pediatric center. And something that's new, and I don't want to say much about it because there's not a lot of data out, but there's been some concerns raised about the safety of gadolinium that we use with MRI. And I've had a few families mention that.
Interesting.
So that's something that we should watch.
Yeah. So number 5, CT scans are not necessary in the routine evaluation of abdominal pain. What do you say to that?
I also so agree. When I was a radiology resident, when there was a rule out appendicitis and ultrasound didn't give the answers, and ultrasound is the first line right now.
Right.
It is exquisite for showing we're giving you the answer. But in a young person, it's a lot of radiation, especially a young girl, to their ovaries. And I think most of the time we can try to avoid it with watchful waiting, the old-fashioned way, and not CT scans.
Yeah, I mean, certainly there are a lot of facilities out there that are not pediatric-based who you're dealing with ER docs who are really just trying to do the right thing. And oftentimes in their minds, the right thing is, let's take this to the hilt in terms of how we can investigate this. We want to be able to give this family some solace in terms of what's going on. And more often than not, that can involve CAT scans that we as pediatricians think are unnecessary.
Right. It's sometimes you don't have to know the exact answer if the risks of this radiation are not worth it. Number 6, don't give high-dose steroids to prevent BPD in preterm babies. Matt?
Yeah.
Do you follow the NICU literature anymore?
I don't.
Me neither.
For the first 5 or 6 years I was out, I really tried to, and then I just found that it wasn't pertinent to what I was doing in practice. That by the time the babies came out of the NICU, pretty much the neonatologist had handled what needed to be handled, and we were familiar enough. The hospital where I trained and where you taught had something like the 10th highest delivery rate in the country. So we got our babies, and by the time we were done our training, we were very facile and comfortable with even the smallest of them. Right.
And about 1 year out of our 3 years of training were spent in the NICU.
Yes.
And we didn't use it. So
no, we were cheap labor.
Now, I was, I don't know if it's when you had already graduated, but I was a residency director when they started pulling the residents out of the NICU by the new RC guidelines.
No, I was
gone. And they were angry. But it's like, well, it's the RC guidelines. I mean, I was very happy to because it was ridiculous unless they went into NICU. And even then, they do a fellowship and learn it. But you spend so much time in the NICU.
So the people who were angry were the neonatology people.
Yes.
Yeah.
And you knew the neonatology
absolutely.
attendings who were mad at me.
Very well.
Yes, it was
Yeah.
It chased me out of that job.
Really? You didn't want to go into private practice of your own volition?
Yes, but having neonatologists yell at you did not help. It was nice to leave.
Number 7, don't perform screening panels for food allergies without previous consideration of medical history. Now, we talked about this a little bit in our allergy episode. But for example, 8% of the population will test positive to peanuts, but only about 1% are truly allergic. So the test really needs to be tailored and interpreted to select possible foods based on a careful medical history, not just on ordering a panel like a shotgun from your hip.
And I'll go further. I more and more will just send them to your allergy to get skin tested, depending on their age, because that could be more accurate than doing the blood testing.
Mm-hmm.
Number 8, avoid using acid blockers and motility agents for physiologic GE reflux that is effortless, painless, and not affecting growth, which I term don't treat the happy spitter.
I concur.
Absolutely. And especially we talked about this summer not giving PPIs.
Right. Right.
to infants if you can avoid it.
There is some risk here. Now, the miserable kids are a different story, and we'll cover them in a future podcast. But because there are actually some leading gastroenterologists who disagree with the fact that we give these kids anything.
Right.
Yeah. So, okay, number 9. Avoid using surveillance cultures for screening and treatment of asymptomatic bacteriuria. Agreed.
Totally. And I guess the corollary now is that don't treat as a UTI if the urinalysis is normal.
Mm-hmm.
If they're growing bacteria but there's no white cells, no inflammation, it's not a urinary tract
And they're
infection.
well,
And they're well.
Yeah, because every once in a while a pyelo will sneak in with a relatively normal UA. But and the child is sick as stink.
Right.
But then you want to probably get an ultrasound and confirm what's going on.
And number 10, infant home apnea monitors should not be routinely used to prevent SIDS, including those smart monitors. Amen. We talked about
We
that.
did. Yeah.
Now, the newest Choosing Wisely list came out last fall, and it's on the section of endocrinology, and I think they're great and really thought-provoking. So, number 1, avoid ordering LH and FSH in either estradiol or testosterone for children with pubic hair and or body odor, but no other signs of puberty. Yes, the premature age anarchy kids. That's usually the diagnosis, and it does not involve the brain's pituitary or the gonads. It's just a normal early increase in adrenal androgens. Now, I used to get a DHEAS, dihydroepiandrosterone sulfate level, which would be high with these, but I actually stopped doing that also if they're otherwise growing well and there's no sign of puberty, just androgen.
Yes. Yeah. And as you I think have pointed out before on this podcast, get the bone age.
If there's any question of precocious puberty, get that bone age. Absolutely. Okay, choosing wisely. Number 2, avoid ordering screening tests looking for chronic illness or an endocrine cause, including CBCs, CMPs, insulin growth factors, thyroid tests, and celiac antibodies in healthy children who are growing at or above the 3rd percentile for height with a normal growth rate. So they're not crossing percentiles and with appropriate weight gain. And even in children below the 3rd percentile for height with a normal history and physical exam, the incidence of newly diagnosed pathology was found to be only about 1% in these patients with significant short stature. So I have also altered what I do with this, that I'm much less likely to start looking for things in a child who's just really low on the growth chart, but growing along the curve. And I think we both agree with that. Okay.
Next, avoid ordering vitamin D concentrations routinely in otherwise healthy children, including children who are overweight or obese. If you're ordering it to get the 25-hydroxy vitamin D level, which best reflects vitamin D synthesis and intake, then you're on the right path if you're going to test for it, but this is really unnecessary in most cases where the child is healthy. Really, you should consider getting the vitamin D only if there are disorders associated with low bone mass, such as rickets or recurrent low-impact fractures or osteopenia on an X-ray. While overweight and obese children do have a higher likelihood of having low vitamin D, as do those with insufficient dietary intake, such as lack of drinking milk, it's more cost-effective to just put all of these kids on vitamin D supplements instead of doing blood work to ascertain the vitamin D level, or, in fact, to encourage them to eat vitamin D containing foods.
Amen to this one also. And this is one that I've changed what I do. I used to throw in vitamin D levels, 25-hydroxy vitamin D, fatigue kids, overweight kids. It's on this panel in my EMR for obesity. And a lot of them would be lowish. They'd be you want it to be 30 or above. They'd be in the 20s, and everybody would be anxious about it. And I'd start them on extra vitamin D. And pretty much now, I put them on a multivitamin with vitamin D, and I don't chase the levels and tell them to go in the sun.
Yeah. Someday we'll have to do an episode, or at least a partial episode, on vitamin D, because I can tell you it's largely misunderstood, including to an extent by me. There's an awful lot of scuttlebutt out there in the scientific community about the pros and cons of chasing these vitamin D levels around.
Next, avoid routinely measuring thyroid function and getting insulin levels in children with obesity. TSH, thyroid stimulating hormone levels, can be a bit elevated in overweight children, but it's rarely due to hypothyroidism. Only consider this screening if the stature or height velocity is decreased. Basically, if an overweight kid is not short and he's growing okay height-wise, you don't need to worry about any hormone issues. So I don't. I get a hemoglobin A1C. I get the fasting glucose. I get a CMP to look for early non-alcoholic fatty liver disease. But I've stopped getting the insulin levels.
Do you get a GGT with that? Because I usually do, just as another liver enzyme that I can kind of present as, hey, listen, it looks like your child is getting some early fatty liver disease. It's non-alcoholic.
Right.
So, and that's honestly, that's one of the reasons why I still do, more often than not, get insulin levels on the kids that I'm evaluating for obesity and its side effects, mainly because I like to be able to, if it's there, present the argument to the patient and the parent that, look, you're essentially burning out your pancreas, by cranking out all this insulin. And in the context that can affect long-term your predisposition to diabetes.
Although what I've read is that's just not accurate.
Yeah.
I've had kids who've had high insulin levels and chased it, and it has to be timed right. So I sometimes will see endocrinology and weight management, check them, but I've dropped it from my routine, and if it's not covered, it's really expensive also.
Yeah. I'll have to reconsider it. Number 5, avoid routinely ordering thyroid ultrasounds in children with simple goiters or autoimmune thyroiditis. Overuse of thyroid ultrasounds leads to parental anxiety and unnecessary imaging otherwise. Fine needle biopsies and other therapies. A careful thyroid exam is vital. And we usually send them to endocrinology if there's a question.
Any question, free T4, TSH, you feel anything different, I'm not even ordering the imaging. I'm sending them to the endocrinology.
Absolutely.
As you know, in kids, they have a higher rate of cancer of the thyroid, and you have to be really careful about fine needle aspirates and doing it right.
Right.
So I give it to the experts.
You bet. Okay, back to the long-awaited conclusion of the Penis Chronicles.
We are back for the final penis finale.
We are going to start this part with a very painful subject. Blunt trauma to the scrotum and testicles. Ugh. Serious trauma to the scrotum is thankfully pretty rare in kids. Although, Rob, did you ever straddle a lamppost on your bike when you weren't looking? I ran right into one, like the street sign on my street.
I thought you were going to say, Rob. I thought you were going to say, Rob, has anybody ever kicked you in the nuts? Because I think most boys have had that experience. Yes?
I don't know. Maybe you more so than me.
I think,
you were fresh, I guess.
Well, the mean streets of Syosset, you had to be aware.
You had to have an edge.
Moments.
Yeah, absolutely. So as you were saying, serious trauma to the scrotum is thankfully pretty rare in kids. It's mostly seen in 6 to 12-year-old boys. That sounds like that was about right. During sports or associated with bike episodes or motor vehicle accidents. Although we're not discussing girl parts in this episode, I think we see more injuries to the groin in girls with straddle injuries than we do in boys. And these can be pretty gruesome, unfortunately. And they're also pretty tricky. The injuries in girls can be serious and hard to diagnose because oftentimes they're difficult to see.
Right. So often they actually need to get an examination under anesthesia.
Yes.
And we're lucky to both have a pediatric gynecologist nearby who's wonderful for that.
Absolutely. So if a boy is injured in this area, the examiner should check for any wounds or changes in the integrity of the skin of the scrotum and also for any obvious swelling or hematomas. Swelling of the testicle, especially if the swelling is hard or tense, is particularly worrisome for a testicular rupture or a testicle fracture. Isn't that like evil? Fractured testicle. Oh, goodness. Also, the urethral opening, where one urinates, should be inspected for a possible injury to the urethra. If there's any suspicion that something more is going on, an ultrasound, back to the ultrasound here, should be obtained and urology should be involved quickly. Because if there's something like a testicular rupture, time is of the essence in order to save the testicle. The scrotum is also a high-risk area for infection, so if there's a penetrating wound, antibiotics need to be given quickly, oftentimes by IV.
Now, if everything looks okay and it's just mild trauma, then you can use ice packs and bed rest, and you can just support the testicle for a while. Perhaps wearing briefs, not boxers, for a while is reasonable. Okay, Matt, boxers or briefs?
Well, Rob, I don't always wear underwear.
Matt goes commando.
But when I do, I generally wear boxer briefs, and that covers both ends of the world.
What are those?
They're like, the squared off tighty blackies. I started to do that when I was hiking and stuff. You've not seen them?
I don't know.
Let me show you.
I'm not an underwear connoisseur.
No.
Anybody out there who wants to compare different boxer brief combos, call Matt.
Boxer briefs. They rock.
All right, so Matt, do you remember Virgil Livers?
Nope.
Maybe because I was in Chicago for 10 years, but long story short, Virgil Livers was a Chicago Bear who was speared in the groin in the late 70s for turning a punt and was not wearing his protective cup. At halftime, they drained fluid from his scrotum, and he kept playing the entire second half. Afterwards, he was rushed to the hospital where he lost that testicle, and simultaneously in the same hospital, his wife was admitted in labor, and they had their baby. So quite a day for Virgil Livers. He seems like a great guy. He's a longtime principal at a high school, and he does lectures around the country on the importance of wearing a protective cup.
So did he have any children after that?
I don't know, but he had that child. But you only need one. Like we said, you only need one. You like
do.
to keep two, but you only need one. And I have to admit, on a serious note, just yesterday I read that they reported the first total penis and scrotum implant at Johns Hopkins Hospital on a soldier injured in an IED blast in Afghanistan, which is amazing and wonderful, and Hopkins covered all the costs.
Wow, that is amazing. Last testicle thing, I promise, and maybe the most important of all. Testicular torsion, or twisting of the testicle. This condition, which is a medical emergency, can occur when a boy's testicle fails to be fixated well in the scrotum. Technically, it's a failure of the normal posterior anchoring of the gubernaculum, called a bell clapper deformity, because it leaves the testes free to swing and rotate within the scrotum. Like a gong. There you go. A clapper inside of a bell. With this condition, the testicle lies kind of sideways in the scrotum and is prone to twisting. Twisting the testes can block off its blood supply. This can occur most often during puberty. There's no easy way to tell if a particular boy will have this until it actually starts to twist. 65% of testicular torsions occur in 12 to 18-year-olds, but it can really occur at any age. When it does occur, there's a sudden pain in one testicle, usually accompanied by nausea and vomiting. If the testicle is not untwisted and repaired quickly, it can be damaged and lost for good.
So Matt, I like to tell all my 11 to 13-ish-year-old boys the testicle story at least once. It's a scary story. It's a true story. So about 8 or 9 years ago, I had a 13-year-old boy who woke up in the middle of the night, went into his mom and dad's room and said, "My stomach hurts." And the parents felt his abdomen, gave him some Tylenol, put him to bed. 4 hours later, he came back saying, "It still hurts, but it's not my stomach, it's my ball." And Dad looked at his scrotum. It was swollen and tender. And I was actually on call that night, and they called me, which was a very, very appropriate call. And I told him to go straight to the children's ER, and I called the ER and the doc and told him that they were coming to give him a heads up. As soon as he hit the ER, they did a testicular ultrasound with Doppler, and there was no flow, and they whipped him up to the OR, where Dr. Sonny performed surgery less than 30 minutes from when he hit the ER door. Now, Dr. Sonny went in and found a completely black, dead testicle. Now, this man, 9 years later, is doing great, has a prosthetic testicle on that side, and is perfectly fine. And again, as we tell our patients, you have 2 of those testicles, but you only need 1, but you'd like to keep both of them. And they always agree. Now, the point of my testicle story is that when you get this kind of outcome and lose a testicle from testicular torsion, it's usually not because the parents didn't do something right away or because the doctor didn't do his job. And sometimes it can't be prevented. But as Dr. Sonny has taught us, it is often because the young teen boy did not tell someone quickly about exactly where the pain was. And perhaps he was a bit embarrassed. But if the boy knew the consequences of waiting, he probably would not be that embarrassed. Thus, the reason for the testicle story. Now, sometimes I forget and tell a boy this story 2 years in a row, and usually he's like, "Okay, I know the story. Stop telling me the story. I don't want to hear the story again." And full disclosure, last year, I had someone come in a year later, and the mom said that he had nightmares for weeks after I told him the testicle story. And I'm a bit more careful about it, but I do still tell the testicle story because young boys need to know that if they get pain that doesn't go away, that they need to tell somebody soon.
In testicular torsion, one side of the scrotum and testicle is swollen and tender and red, and the testicle itself is a bit higher in the scrotum. There's also a decreased cremasteric reflex, there's that muscle again, where normally, if you touch or brush the upper inner thigh, the testicle on that side rises, but not when there is a torsion present.
Now, the differential diagnosis of painful swelling in the testicle area includes the common and more benign condition called torsion of the appendix testes. This is where a small embryologic remnant, kind of like the appendix on your colon, can twist and cause a tender localized mass at the top or bottom of the testicle. This could then turn black or gangrenous, and you can see it through the thin skin of the scrotum, and it can look a bit blue. Thus, they call it the blue dot sign of torsion of the appendix testes. And yes, I've always been taught that you can diagnose this clinically, but unless I'm completely 100% sure that that's what it is, I'm getting that ultrasound and Doppler if there's swelling. If it's a torsed appendix testis, it's treatable with bed rest, pain meds, and support of the scrotum. How about you, Matt? Do you routinely diagnose these without getting the ultrasound and the Doppler?
No way. There are some things you just want to be absolutely sure on. And so it's like, I don't mess around with eyes if there's a question. I don't mess around with testicles if there's a question.
Right. No, Dr. Sunny probably can say, you know what? You don't need an ultrasound, but not me.
Yep. Another pretty common cause of swollen, painful scrotum is epididymitis, which is an inflammation of the epididymis we discussed a few minutes ago. With this, the scrotum can be red and swollen, but usually the cremasteric reflex is okay, which is not the case with a torsion. And usually the pain lessens when you elevate the swollen testicle, whereas in true torsion, it does not feel any better. That's called the Pren sign. And although I learned it as a medical resident, it's not totally reliable.
It's totally not reliable.
Yeah, so if you're in doubt, get the ultrasound with a Doppler flow to rule out a true testicular torsion. If you think it's epididymitis, get a urinalysis and a urine culture, and obviously check for STDs if the young man is sexually active. If the epididymitis is not bacterial, it can be treated with rest and ibuprofen and even perhaps an antibiotic to assure coverage anyway. One of the few times we do that type of thing. The last cause of testicular swelling is mumps orchitis. In 1967, there were at least 186,000 cases of mumps in the U.S., which went down to 229 in 2012, thanks to the mumps vaccine. Woohoo! The last few years, the number of cases have started to rise, with over 8,000 last year, the highest in 10 years.
Which is amazing.
Amazing. Sporadic mumps outbreaks are happening, especially on college campuses like in Arkansas and Iowa and in Illinois and Ohio. There's even been a recent outbreak in the NHL.
Not on the Flyers, but maybe that's why they were so terrible against the Penguins this last
they
week.
Were awful. Yep. A big difference in most of these outbreaks compared to outbreaks of other vaccine-preventable diseases like measles is that most of these kids were vaccinated. There's talk of routinely requiring a third dose of MMR in the future. Mumps orchitis is no joke. It can decrease fertility permanently.
And we are having a mini outbreak in Delaware with 19 cases of mumps this month, mostly in older adults, but also in a 1-year-old, all traced pretty much to a Mexican-themed dance at the Chase Riverfront in February, then again in March. Did you go to that dance, Matt?
I did not. Yeah, my dance card was full that night. I had to go to the Hustle dance celebrating the 70s. Down at the other place.
But now we're both on the lookout more for mumps, which usually has swelling of the cheeks and the parotid glands. But if you suspect mumps, one little nugget that I recently learned from our infectious disease person is that the best way to diagnose it is a buccal swab for a PCR of mumps RNA, and also that mumps has a 25-day incubation period. And once again, that gets to a theme of our broadcast, get vaccinated.
Yeah, even though the people who had gotten these mumps were largely vaccinated, that doesn't mean the vaccines aren't worth it. Look at all the people who didn't get it. And if anything, perhaps another dose should be required.
I think 10 years from now, we'll be giving a third MMR dose before they go off to college.
Mm-hmm.
Lastly, some common skin findings of the penis. So this is not a common complaint, but we sometimes will see a teen boy come in for fatigue or a cold or something, but what he really wants to talk about is that there's something on his penis that he's worried about. So the first penis rash that we as podcast pediatricians will mention, because we love our P word alliterations, is Pearly Papules of the penis. And that's different than Puppetry of the Penis, Matt's favorite Broadway show, which he will discuss at a later date. So Pearly papules of the penis is a benign condition where there are small dome-shaped
Nice. This
skin
is like junior high.
colored papules. It's worse. At the edge of the glands of the penis, or even into the sulcus, which attaches to the penis shaft. There may be multiple rows of circumferentially tiny papules that are completely benign, but they can freak out teen boys. Have you seen this?
I have, for sure.
Yeah.
And it does. It completely freaks out boys. They think they have some type of... it looks like...
Rows of tiny little bumps all over the
How can I have an
glands.
STD? I didn't do anything. Yes, very concerning. Another even more common benign condition is called Fordyce spots, which are 1 to 3 millimeters, white or white-yellow bumps, usually on the shaft of the penis and sometimes in the scrotum, that are really just benign enlarged oil glands or sebaceous glands. They're often associated with hair follicles. Have you seen these?
I have, and it's usually I see it in the scrotum, and I never knew what they were called. I just like, oh, that's okay.
Right.
Don't worry about it.
Those are little scrotum bumps.
Right.
Okay, this episode's not about sex, but we will do an episode on sex in the future, and we would be remiss if we did not mention penile findings of some of the sexually transmitted diseases. First, there are genital warts, which are caused by the HPV virus, and that can be mostly prevented by the vaccine. They're not very attractive and can be treated with freezing and topicals, which we usually leave to the dermatologists.
Absolutely. But Matt, do you freeze warts, regular warts, common warts, plantar warts in the office?
We tried that briefly at my office, and what we found was it takes generally more than one session to freeze most warts. The skepticism of the parents started to kind of erode our practice of that because it was like, well, geez, I could have just gone to the dermatologist and gotten this done 3 or 4 times,
Right. Now, the dermatologists will use liquid nitrogen.
Yes.
We just restarted up. There's some new products out. I'm not going to use their name yet, but they're not as cold as liquid nitrogen, but they're much colder than the over-the-counter freeze therapies. And 2 for 2, plantar warts worked really well.
Wow.
I didn't even have to refreeze it. So
Great.
I'll let you know.
Yeah,
but it's
please do.
kind of fun to do something different.
Yeah, well, we're so procedure starved as pediatricians. It's nice every once in a while to have something that we can take care of right then and there.
Right. And finishing with the STDs, there are also penile chancres, which are the primary lesions of syphilis. It's a firm, round, impressive lesion that is almost always on the boards. I saw it once in an STD clinic in med school, but I've not seen a case in my practice, although nationally the incidence of syphilis is rising. And then there's genital herpes lesions, which have characteristic sores and blisters and are tender. One last thing about the scrotum, because it's so thin and stretchy, it swells up easier than other skin, just like your eyelids. And one classic cause of scrotal swelling can be Henoch-Schönlein purpura. And anytime I have a child who has swelling around the scrotum, there's no obvious reason, I always check the urine to see if they're spilling protein so I don't miss a nephrotic syndrome.
Yeah. Speaking of that, I don't know if I ever told you about this one, but it was my first day on the internal medicine service in medical school, and I was taking care of a gentleman who, unfortunately, was a pretty sick guy. He had kidney failure, but he was also pretty non-compliant. And this guy had a scrotum so big that when he came into the hospital, he carried it in a bowling bag. So it was very impressive.
Thank you for sharing that.
Yeah.
Thank you for sharing
you
that,
can picture
Matt.
that now, can't you?
Yes.
Yeah.
Thank you.
Can you imagine? That would be a difficult walk down Broad Street, I would think. Anyway, moving on. I think the most common reason for scrotal swelling with rash, which we both see in practice, is contact dermatitis, specifically poison ivy.
Yep.
When you see boys with poison ivy on their arms and their face, always ask about their privates. Whether they transferred it off their hands when they were peeing after the exposure, which oftentimes they do. Boys are out in the woods. What do they like to do? They like to pee. Or is it just due to the fact that boys like to put their hands down their pants, which oftentimes happens?
Why not?
And it can be pretty severe down there and so uncomfortable. Topical steroids can be helpful, but just like when there is a severe poison ivy of the face, sometimes a short course of some steroids is needed. What kind of doses do you use, Rob? Do you do that?
Good question. I find that even my partners, we all do different things.
Yeah.
The person I took over from Dr. Matt, the other Dr. Matt, he used to use 1 per kilo for 5 days. And I just did what he did, and like a maximum of 30, I think, in a day.
Right.
And then a lot of my partners just use a Medrol dose pack, which makes sense. You start high, the 24 milligrams, and go down. So I probably have gone to the Medrol dose pack more lately.
Yeah.
How about you?
I'm a little bit more aggressive. I'll usually treat it because I had, not under my care, but I had seen while I was working in the emergency room, a couple of kind of bounce back type of situations where it was treated for too short a duration. So I'll usually do 2 per kilo for the first 2 or 3 days. Then
Per day?
Yep. Then 1 per kilo for the next 2 or 3 days, then half per kilo, and then off. So
Gotcha.
It's usually about 9 days, 9 or 10 days.
Maybe I'll start to do that.
Why? Your thing's working. I'm
then
thinking
I
pretty
come
much
back.
any reasonable dose of
Right.
a steroid is going to be helpful in that situation.
Lastly, this specific podcast is not about sex, but we should mention the subject of erectile dysfunction, or ED, which can come up even in teenagers and young adults. Have you had this complaint in your practice, Matt?
Yeah, in a couple of the young men, they've asked me about it for sure. In fact, the top causes of erectile dysfunction in adults: long-term or poorly managed diabetes, hypertension, smoking, and associated cardiovascular disease are rare in adolescents and young adults, although type 2 diabetes is on the rise. Erectile dysfunction in the pediatric age range is often linked to being overweight, but most of the time, erectile dysfunction is psychological, either depression or anxiety or a combination. The examiner should specifically ask about bicycling, since excessive biking can also cause erectile dysfunction. Again, in this situation, you want to ask if they've ever had an erection, if they masturbate, if they have more of a performance anxiety than absolute persistent erectile dysfunction.
Now, certainly one reaction I might have when a teenager or college-age guy comes in saying he's having difficulty having sex is, great, I don't want you to have sex. But this is a serious issue for that young man and causes much distress. Although I keep telling him, I think we both keep telling him, to practice abstinence. Now, a testosterone blood test can be reasonable in these situations, especially if there's no erections. And again, if it's clearly related to anxiety, then talking to psychologists can be helpful. And if I'm not sure, and I think that there's a chance that it's not just from stress or anxiety, then I will have them see a urologist, because there definitely could be a blood vascular disorder causing the problem. Matt, have you ever had anybody ask you to prescribe Viagra for them?
You mean besides like neighbors? No, actually, I've never had any of my patients ask me for that. But getting back to what you said a second ago, the handful of kids that I've had who have approached me about some degree of erectile dysfunction, almost to a person, they were extremely stressed out. For any number of reasons, and really had good success in terms of just sitting down and talking to a counselor or a psychologist. I think that, to a person, it was resolved.
Right. Yeah. I've had a couple of times in college-age young men who had a negative workup, went to urology, they were talking to a therapist, and I talked to their therapist that I did prescribe a short course, a few pills to just jumpstart things. And in this non-scientific 2 out of 2 survey, both of them, it helped, and then they went on to not need anything. So I think there can be a role, but it's not something that pediatricians get into very often.
Okay. Well, that wraps it up. That's it for now, gang. We will be back soon.
And again, keep telling your friends and frenemies to listen and subscribe on iTunes, Google Play, Stitcher, and check out podcastpediatricians.com and leave your email on our mailing list so you can give us feedback and suggestions. And don't forget to contact our sponsor, Triage for Pediatrics, at 214-450-5030 or jortiz@triageforpediatrics.com for all your pediatric call covering needs. And stay tuned for next episode, where we will be unveiling our second sponsor.
Whoa.
Say goodnight, Matt.
Good night.
Sei gesund.
I got your picture, I got your picture. I'd like $1 million of your aura myself. I want a doctor to take a picture so I can look at you from inside as well. You got me turning up and turning down, I'm turning in, I'm turning right, I'm turning Japanese. I think I'm turning Japanese, I really think so. Turning Japanese, I think I'm turning Japanese, I really think so. No sex, no drugs, no wine, no women, no fun, no sin, no you, no wonder it's dark. Everyone around me is a total stranger. Everyone avoids me like a cyclone ranger. Everyone. That's why I'm turning Japanese. I think I'm turning Japanese. I really think so.
Podcast Pediatricians Productions. All rights reserved.